Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to this evening's Lung Cancer Living Room. We're so happy to have all of you. As some of you may know, tonight's conversation is around personalized medicine, diagnostics, and treatments. And we are thrilled to be able to have Dr. Roy Herbst, MD, PhD, Chief of Medical Oncology from Yale Cancer Center and Smilow Cancer Hospital, here with us tonight. I think the last time Dr. Herbst was able to do a living room with us was a few years back when we were actually out there on the East Coast in his neck of the woods. So welcome back, Dr. Herbst. For those of you who are maybe new timers or first timers to the Lung Cancer Living Room, welcome, welcome. I'm Danielle Hicks. I'm Chief Patient Officer here at GoTo Foundation for Lung Cancer, joined, of course, by our very own Bonnie Adario, who is a doesn't really need an introduction, but I'm going to go ahead and let her give one in just a minute. For those of you who are first timers, our Lung Cancer Living Room is an opportunity for us to bring to you expert speakers across, varying aspects of the disease. And I already told you a little bit about who tonight's speaker is and what the topic's about, but we're really here for you. We've built this for you, with you in mind. So thank you for joining us. And for those of you who are regulars, welcome back. So wherever you're watching from, we're thrilled to have you here tonight. Before we jump into the program, I always like to have our speakers, including Bonnie, introduce themselves and talk a little bit about who they are and why lung cancer became a primary area of focus for them. So I'm going to turn to you, Dr. Herbst, and ask you to introduce yourself and tell us why lung cancer matters.
Yes, hi. So I'm Roy Herbst. I'm the Chief of Oncology here at Yale. I also lead the lung cancer program, and I've been working in this area for almost 25 years. And it matters because, when I was a fellow at Dana-Farber, back in the early 90s, no one wanted to work in this field. Everyone wanted to work on other cancers where there was much more progress. And I was very fortunate that there was a Dr. Tom Fry who encouraged me and Art Scarin to work in this area of lung cancer, saying we need to make progress. We need to see new drugs and personalized medicine. And I was very fortunate. I then went to MD Anderson, where the EGFR inhibitors were just about to go into clinical trial. So working with Kihan and John Mendelsohn, I saw personalized therapy at its best. And now, so many years later, we're seeing benefit. And that's what makes me tick, going into the clinic, running clinical trials, finding ways to help patients with lung cancer. And we're continuing to do that here in New Haven at Yale and throughout our entire network.
That's great. Thank you. And Bonnie, AKA Mom, tell us a little bit about who you are, for those who may not know.
Thank you, AKA daughter Danielle. I'm involved in lung cancer because I was diagnosed myself 17 years ago. My mother died of lung cancer, my grandfather died of lung cancer, and my aunt and uncle died of lung cancer. So lung cancer has invaded our family in a huge way. So I started a foundation, pretty much out the chute with my family. And we're here today after all of these years. But I just want to point out one thing that Roy said, which is so exciting to me because it was not the way it was when I was diagnosed. More new therapies in the last 5 years approved by the FDA and actually approved very quickly by the FDA, really than the last 5 decades. An amazing amount of new therapies for lung cancer. So these are exciting times for lung cancer, and Dr. Herbst is going to tell us about some of that excitement tonight.
That's great. I think personalized medicine, it's something we come back to a lot because of exactly what you're talking about and how quickly and rapidly things are changing. So we want to be able to bring that information to you so you can then go back and have informed conversations and make informed decisions with your healthcare team. So with that, because I know we are sort of time limited, I want to jump right in, and I want to talk about precision medicine from a diagnostic standpoint. And I want to start, Dr. Herbst, with a conversation about what are proper diagnostics. Can you explain biomarker testing, why it's important, and when a patient, why it's important when a patient's cancer is biopsied to have this testing? Uh-oh. Hang on, Roy. I think we lost your audio. Sorry. They're checking. Oh, there you go.
Lung cancer is a very heterogeneous disease. And, everyone with lung cancer has a slightly different, genetic makeup. There are many people who get lung cancer who have smoked, but very many now who have never smoked. There are people who have had exposures to different chemicals. It varies depending on where you live. So it's very important, to know exactly what's causing that lung cancer to grow so we can attack it in the best possible way. When I started out, we used to have what we called non-small cell and small cell. We still do. Within non-small cell, the most common type, there's squamous and non-squamous lung cancer. But now we want to do a molecular profile. We want to know one of 7 or 8 genes, different parts of that cancer that are causing that engine to tick. Because if we can understand what's causing the cancer to grow, we can match it with a specific therapy. That's what we call personalized medicine targeted therapy. So it's very important these days to know that. There are also markers we look at that tell us about the immune system and the immune function. And these are all things that, as Bonnie said, are growing and escalating so rapidly. And it's amazing because now we can match the right person with the right drug at the right time in many cases, and that results in much more effective therapy.
That's great. I think, I just want to kind of reiterate what you're saying, and make sure that, our community understands that these mutations or these biomarkers are what are driving the cancer, right? And that it's important to know not every cancer is the same, and a lot of them have different drivers. So identifying these up front ensures, to your point, what you said, the right drug to the right patient at the right time. And I want to, go back to what Bonnie was saying. 17 years ago when she was diagnosed, EGFR had been identified, and there were, trials happening. Unfortunately, she didn't have biomarker testing, so we don't know, whether or not she did have a marker. But since then, we have identified all of these different biomarkers, specifically in non-small cell lung cancer, right? Is there anything happening in some of these other different types of lung cancer, whether it be squamous, to your point, or even small cell? Are biomarkers, starting to be identified in those areas?
Oh, absolutely. Many of these molecular targets, as you allude to, are in the non-small cell lung cancer, and specifically the non-squamous or the adenocarcinomas. But in the other types of lung cancer, squamous lung cancer, and in small cell lung cancer, now immunotherapy is really become a mainstay of that therapy. If someone has a squamous lung cancer, and most of those patients will have had smoked at some point in their life. Many of them will have stopped, but unfortunately, even after you stop, you're still at risk. Some may not have. The immunotherapy, checkpoint inhibitors can have a really, profound effect. And now small cell lung cancer, just in the last 3 or 4 years, we've seen positive results for immunotherapy in small cell lung cancer. And by the way, a number of different markers that are beginning to portend therapies there as well. So the more we look, the more we'll find. And that's why clinical trials and research are so important. Because not only does that mean you're probably getting a therapy that's on the cutting edge, but it also contributes to the advancement of the field. We're continuing to learn. And I can tell you, I've seen this firsthand, having done this for nearly 3 decades. We're continuing to make progress. We're not enough yet, but we're continuing to raise the bar. And as Bonnie alluded to, with EGFR, and you alluded to with EGFR, we started using some of these therapies before we even understood the full molecular pathway and how they work. I still remember meetings with Bonnie and the foundation, at our lung cancer meeting, 15 years ago, where we were seeing patients who were benefiting from these drugs, but we still didn't know why. And that's where we started collecting patients and bringing together registries. So progress is being made, and the foundation's had a big part in that.
That's great. And I think it further sort of solidifies what we're saying. I want to talk a little bit about the different types of biomarker testing. And I know we were discussing a little bit beforehand in the green room, if you will, before we went live, about comprehensive biomarker testing versus maybe single gene panel testing. Can you talk about the differences in both and how what is your sort of gold standard when working with your patients?
Well, first of all, my dream, my goal is to get testing available to all patients, no matter where they live, who their physician is. And that's happening, but not as fast as we would like. We actually have a trial called the Lung Map, the Lung Master Protocol, which is a public-private partnership between the National Cancer Institute, the Foundation for the NIH, the Friends of Cancer Research. Many foundations help support it, the companies that supply the drugs. I would always advocate, if you can, do a comprehensive profile. Why? Because there's not just one marker. There are now, at my last count, 7 or 8 different biomarkers that we can then now match that patient to a specific drug. So if you just do one, what about the other 6 or 7? And sometimes the samples are quite limited. So next generation sequencing and profiling is what I would advocate doing. Certainly, the gold standard has always been to do it in the tumor, so have tumor tissue. But now we can even use blood. We can even, find those that circulating DNA and measure it in the blood. That's especially useful if someone were to have uh, an abnormality, be treated with a specific drug, and then if something happens and they start to grow, the tumor starts to grow again. You can sometimes use the blood. In fact, we do it all the time, and then understand what's changed and how can we then match another therapy, add something on, a combination. Sometimes we use immunotherapy. So these are all things that we're doing in real time, and we're also using these tools in clinical trials.
Yeah, I think that's a great point. The comprehensive testing oftentimes looks
Danielle.
yes. Can you hear me?
Yep.
I don't hear you.
Oh, sorry. Sorry, we tapped out for a second there. But I think talking about the comprehensive, biomarker testing or next generation sequencing, as you referred to, quite often is looking at several hundred different mutations. So not just the 7 or 8 that we know have, FDA approved targeted therapies for them. But the reason that that's important, to your point, is because these clinical trials that are happening that are looking at drugs that can target some of these biomarkers. So, and we're going to talk a little bit about that in a minute when we get into some of the treatment options and why these things are important. But I think driving that point home and your belief that, and dream that everyone should get this type of comprehensive testing at diagnosis is that of
Well,
go-tos as well.
right, and a place like Yale, NCI Comprehensive Cancer Center, we have Dr. Pat LaRusso who leads a phase 1 unit. So if you get 100 or 200 genes sequenced, there might be something that can be linked to an early phase trial. So patients can come in, and then we're not just picking something because it's available and we want to put someone on that study. We're matching them with science. We're increasing the odds that will work. And that's something I've seen throughout my entire career. Use the best science that you have in real time to raise the bar, help people do better with this disease. And now more than ever, we have to personalize the therapy. So I'm so happy with our Lung Master Protocol that's provided free, and that we have this open at 780 sites around the country, so patients can get this profiling. And that, by the way, that's patients from all ethnicities, socioeconomic groups. So we're beginning to get an understanding what is the distribution of these different mutations, so that we can get the right drugs throughout the world.
And Roy, could you talk about MAP a little bit more? It's my belief that a patient can be on one clinical trial in this MAP program, and if that particular portion of the trial fails that patient, they can actually move over into another drug within that uh, program,
Absolutely,
right?
Bonnie. And yeah,
Multiple,
just Friday
multiple
we put the last Friday we put the first patient on the lung map trial on a new sub-study that targets KRAS. When I was growing up in this field, and still it's a tough target, KRAS was the holy grail. You could not attack it. There were no drugs. And now we have drugs. There have been data at the ISLAC, the International Association for the Study of Lung Cancer meeting, held virtually from Singapore in January. We saw amazing data, a phase 2 study, the Codebreak trial, for these drugs. And we're now seeing these drugs being made available to patients. But the problem is it's 12% of patients. So in order to find those 12 out of 100, we've got to make sure all 100 are sequenced. And this trial is putting them on that study. Now, if they were to then progress and fail that, we would then re-biopsy, and we would, or maybe a liquid biopsy, and then try to put them on something else. So that we're constantly trying to find something better for them.
I think it's a very
Exciting.
unique and special trial, yeah, and it is very, very exciting. So we've talked a little bit about upfront, diagnostics and the importance of biomarker testing then, and we touched a little bit on, further biomarker testing down the road, potentially at progression. Can you talk about why that's important? Because I think a lot of folks don't actually have access to biomarker testing at progression.
Right. Well, with the targeted therapies, and I think I must have treated my first patient with an EGFR inhibitor in 1997, if you can believe it, that long ago. These drugs, when they work, it's amazing. It's like putting a key in a lock. But the problem is these cancers are just so insidious and so smart. And what they'll do is they'll learn how to become resistant. So with time, the cancer will become resistant and it will start to grow. At that point, it's my belief that if you can, either by biopsying the tumor, this is where the blood biopsies come in, because sometimes the tumor's in a hard to biopsy place, you get some more sample and you resequence, and you might see the original abnormality, or you might see something different. And that's where the research comes in, the clinical trials come in, because we might have another drug to use. We've seen that in our own lifetime with epidermal growth factor receptor. The first drugs were gefitinib and erlotinib. And we then learned that about half the patients became resistant with another mutation, not that important for tonight, but I'll just mention it, T790M.
Yes.
So
Yeah.
but then there was a new drug, osimertinib. And so that drug, not only was it able to attack that new mutation, but it also was a better drug in that it was more specific. There were fewer side effects, not without side effects, but fewer side effects. And then that actually resulted in our ability last year to actually show data that we could actually start using that data, so that drug, in people whose lung cancer had been cut out or resected. So we've moved these drugs to the earliest stages of disease. So drug development has continually progressed because we rebiopsy, we understand resistance, and we're developing better and better drugs.
Could you say a little bit, Roy, about all the newly diagnosed patients that are on the call tonight? Because they're overwhelmed by this diagnosis. They don't know anything about lung cancer. Their physician has put them on one drug, and they don't really know why. They may have had genomic profiling and don't even know. But what can you explain a little bit about what happens after they've had one drug, they've progressed, and how often there are more opportunities for them along the way? Our goal tonight is for you to give a lot of these folks a lot of hope, knowing that upon progression, there are more opportunities with testing.
Absolutely. I was just in the clinic this morning, and as you would imagine, many patients come in and they've been on some of these drugs and they've done quite well, but then the tumor starts to grow, and then you have to make a difficult decision what to do next. And certainly this is where the expertise might come in of the cancer centers. Since these tumors are still somewhat rare, there are major centers that might see more of these, and I often reach out to my colleagues for advice as well. I would say that if you have a tumor and it starts to grow, you want to try to rebiopsy it and see what's happening, and then you ask what are the other genetic factors in play, and then look for new drugs and new combinations. Now we have antibodies combined with what we call small molecules, oral agents. The antibodies being IV. Sometimes we can use a new drugging class. Occasionally we'll use chemotherapy. We're even starting to look at immunotherapy. But this is where I would I would ask your physician, do you have a clinical trial? Is there anything else that one could try? I'd go online. Advocacy groups are so important, both for information, but also to have a friend to talk to. There are groups called the EGFR resistors and ALK and ROS1 and all the different groups. Many of those people are probably on this phone call. There are so many people who are living with this disease, and I stress living because that's what you can do with lung cancer now that couldn't happen many years ago because of the advances we've made. But still, one has to use all the resources available to him or her, to search out the best drug for their particular problem, and that often involves, checking with a colleague. Today, I spoke to a physician by email at Mass General as well as one at Memorial Sloan Kettering about a patient because, any doctor who you'd want to see should be reaching out and using the entire network. And, this is something that the GoTo Foundation and others are very strong at doing, bringing people together. Someone in that room will ask, is there something better? Is there something else? And by doing that, you're at least making sure you get the best standard of care, and hopefully you'll find something that can even push things a little bit higher.
Exactly.
Yeah. I was just going to say, some of the stuff we've been talking about, up until now in this biomarker space, where we're talking about late stage patients, right? Where it was previously believed that these were the patients that should have this type of testing. But some really interesting information came out and some data came out around ASCO or at ASCO last year around the ADORA trial and looking at biomarker testing in early stage patients. Can you talk a little bit about that, what that trial showed and what's been happening since?
Yeah, absolutely. I was very fortunate to be the person who got to present that at the virtual ASCO last year. And that was a trial we started about 5 years ago. So the idea was, we were using these oral agents, these EGFR inhibitors, in the most advanced setting, and we were seeing some benefit. But as we talked about, tumors would become resistant. So the idea was, why not take these drugs and use them even earlier, in lung cancers where you've cut them out. But as you know, even if you've cut a lung cancer out, there's still a chance that it could become recurrent. So we were very fortunate the drug that we were studying, osimertinib, the third generation EGFR inhibitor, was much more selective, meaning it had far less toxicity, was a bit more potent, and it also had very good penetration into the brain. So that made this drug a perfect drug to use in what we call the adjuvant setting. And this trial that was multinational, it was almost 800 patients, across all continents. About actually 2/3 of the patients were treated in Asia, where EGFR is a bit more common. This trial basically took patients with stage 1, 2, and 3 lung cancer, all lung cancers that could be cut out. The patients then had the standard of care chemotherapy if they were appropriate, but then they either got this pill, the osimertinib, or a placebo. And you might ask, how could you give someone a placebo? Because there was no standard of care. Nothing was being done. If someone had an EGFR mutation, we just watched them. And about this time last year, I got a call that the trial had been unblinded. I hadn't expected to see the results for a couple of years. And that's because when they were reviewing the data for safety, they saw an 80+% improvement in those patients who got the osimertinib, the pill, versus the control group. And we expected the trial would be positive, maybe 20, 30% benefit, but 80%. So that actually resulted in the trial being presented at the ASCO. It went from the data to presentation just in 6 weeks. And it also resulted in a paper last October, and actually came out in August, but then it was published in October in the New England Journal of Medicine. So that, I believe, is how the paradigm is going to shift. Use your best drugs earlier in disease. Hopefully in that setting, the tumor doesn't have time to grow with enough cells to become resistant. So it's my hope that when this trial is finally reviewed in a few years for whether or not patients survive longer or not, it's my hope and expectation they will. We're still waiting for those data. But I will tell you, when we looked at those patients, so far fewer of them had disease that went to the brain, the liver, and the bone, what we call metastases. So that's progress. And I would predict it's not happened yet, but it's about to, that all the targeted therapies will start moving to earlier disease. And actually, we're going to see at ASCO this year that immunotherapy is moving to earlier disease. And that really takes everything full circle, because it's always been the case. And I mentioned at the beginning, my mentors, when I went into lung cancer, they always we were using chemotherapy back in 1994, but we always brought our best chemotherapy earlier. So imagine if we can bring our best targeted and immunotherapy, more active, fewer side effects, use it earlier. It really is a very exciting time to test these agents to help more patients.
Yeah, I think this
Right.
is
I'd really love you to tell these patients or explain to these patients a little something about chemotherapy, because so many are really, really terrified of going on chemotherapy. I'm sure you've got some patients too that say, oh no, I don't want to do chemo. But we have found that chemotherapy is still a very good player in the unique positions with these patients. Can you talk about that just a little bit?
Yeah, it's funny. I still remember around 2002 or three. I was giving grand rounds at MD Anderson. I worked there for 13 years, and Jay Freireich, Emil Freireich, was in the audience, who was one of the old guard who actually developed chemotherapies. And I talked about personalized medicine, and he got up and raised his hand and said, "Well, chemotherapy is personalized too," and he's absolutely right. Chemotherapy was developed to attack dividing cells, whether it be the DNA, the apparatus that allows cells to split and grow. It's just that it's not quite as specific as some of these more targeted therapies we have now. But chemotherapy definitely has its place in lung cancer. And one thing that we have to make sure people understand is chemotherapy with drugs like cisplatin and carboplatin, being used in patients who have had tumors resected or in combination with radiation, that can cure lung cancer too. So you mustn't forget that there are side effects. So you have to, sometimes people look at me, you're going to give me chemotherapy? No, it's part of the equation. We know now, which we didn't know 20 years ago, how to treat some of the symptoms quite well. Whether people always worry, will they feel sick? Will they be nauseous? We have great drugs for that. We understand the side effects, some of the sores, mouth sores, and fatigue and other things. There's so many supportive care measures now. So I would always say, if chemotherapy is indicated, don't shoo it off. It can certainly help. And now we can combine some of these new therapies with chemotherapy. That might be the special sauce you need, a little targeted therapy with a chemotherapy. So it's still part of the equation.
Yeah. Thank
Yeah, I
you.
think that's
Thank you.
important. And we're going to talk a little bit about palliative or supportive care in a minute. And I think it's the chemotherapy sort of arena is an important space for that, specifically because of side effects. And that tends to be patients' big worries. But before we jump over there, I want to go back to this earlier stage patient, these folks who qualify for surgery, because I think it's an important space, knowing that roughly 40%, give or take, of patients who do have surgery will wind up relapsing, or their cancer will come back. So I think, what we're seeing and what you just talked about, that came out of Adora and osimertinib, and what we're looking at there is a huge win for a lot of patients, to your point, particularly when it comes to brain metastases. You mentioned adjuvant therapy. Can you explain a little bit what adjuvant therapy is? How we historically treated patients in that adjuvant setting, and speaking of chemotherapy, right, going back to that. But you said adjuvant, and I just want to make sure that our folks watching know what adjuvant therapy means.
Right. So, and you say it very well, so if you have a lung cancer, let's say uh, an inch or two or 2 centimeter tumor in the lung, you cut it out, as you mentioned, there still could be as much as a 50% chance the tumor can come back. And depending on the size, the stage goes up to stage 1, 2. Stage 3 lung cancer has lymph nodes in the chest. And those cancers, even when you do what we call an R0 resection, that's fancy surgical terms for you get it all out. So you get it out with enough space between the margin, the knife, and the tumor that you can see that it's clear. It still can come back. So when you treat now for what you would call micrometastatic disease, the cells you don't see, it's basically like buying an insurance plan. That's where the chemotherapy comes in. And we call that adjuvant chemotherapy because it's therapy in the absence of any visible disease. And that has been shown to improve survival, but on the order of 5 to 10%, but it does improve survival. And I would contest that that's going to be used along with the targeted therapies, the immunotherapies, because it's good and it's standard of care and it should be, and it actually improves overall survival, but not nearly as well as we would all like it to be. And that's why I predict in the next several years, We're already seeing the Adora work where people, now approved. The drug became approved last December, the osimertinib. So you can use it in the United States. Now, there are going to be side effects that you wouldn't see if you were doing nothing. You're taking a drug, but I've been using it now in my practice. And now I think we're going to start using immunotherapies in this setting as well. We already are in stage 3 disease. I actually think stage 3 lung cancer is the most fascinating area because that's where you have a tumor, some lymph nodes. You use all your tools. You can use surgery, you can use chemotherapy, you could use radiation. And then about 2-3 years ago, there was a trial called the Pacific trial. I know you're both in California. So the Pacific trial actually then used durvalumab, used an immunotherapy after, and showed, a 50% improvement in survival. So we're using all of our weapons. The problem is we have to understand when to use them, how to use them, and that's where the personalized medicine comes in. The biomarkers, what's happening with the immune system, what's happening with the cancer and the targeted platforms. And it's really exciting. But my goal, as an academic physician at Yale, working with the National Cancer Institute, the Lung Map, is to make sure this is available to everyone. And hopefully with programs like this, people will go online and they might seek a second opinion. And what's amazing? We can do video consults now. Now, this has been such a horrible year, but I now have a very nice iPad sitting on the desk next to me. And 2 or 3 of my visits today in the clinic were by video doing other opinions. So I think that's going to help raise the bar so more people will learn about these issues and seek the right care.
I think the telemedicine that you just referred to is such an important part, with COVID being so devastating for so many reasons for really everyone in the world. There are some silver linings. And I think the use of telemedicine that has come out, due to COVID is something that's here to stay even after COVID is gone and going to be play such an important role in people's healthcare across the board, not just in lung cancer, but across the board in a really positive way. So we talked about adjuvant therapy. There's also something for these earlier, surgical patients called neoadjuvant therapy. Can you talk a little bit about that? And there was a recent news story coming out of AACR around this type of therapy and this IO chemo combination, and you touched on it a little bit. But can we talk a little bit about what it means in that sort of pre-surgical setting?
Right. That's fantastic. And I always thought of that as, we learn a lot from a neoadjuvant trial because we're giving the therapy before the surgery. So as opposed to cutting the tumor out and then giving the therapy, now we give the therapy and then cut the tumor out. So we actually can see the results of what we did. And about 2.5 years ago, Drew Pardoll and his group from Hopkins and the group from Memorial had shown that a drug called nivolumab, one of these checkpoint inhibitors, in about 20 patients, could basically shrink many of these tumors to the point where the surgeons would be amazed. They'd say, I'm operating on a tumor, and the tumor would be almost completely gone. And then actually look under the microscope and see that there were very few, if any, living cells. But that was a small trial. This Checkmate 816 that was just presented at the American Association of Cancer Research by Patrick Ford, what this trial basically did is it had about 160, 170 patients in both of the different parts of the trial. So it was a large trial done at multiple sites. And half the patients got chemotherapy and then surgery, and the other half got chemotherapy plus the immunotherapy, the nivolumab, and then surgery. And incredibly, in those patients who got the immunotherapy at the time of the operation, a quarter of them, there was no tumor anymore. Anything that they removed was completely dead, versus in the group that was in the control, only about 1 or 2%. So very few. So I think, that still has some ways to go before it becomes standard of care. We need to see that's just the first endpoint. The next will be, do patients have less recurrence of their disease? And then ultimately, do they survive longer? But isn't that fantastic that you can maybe make the tumor smaller, do a lesser operation, leave more lung because, we worry about, the effects that might have, on breathing and so forth. But also to get the cancer when you can see it, the tumor's there, knock it out, and then do the surgery. So I would predict we're going to see many more trials like that, as well as more trials in the adjuvant setting. The problem we have is it's working in both settings. There's so many variables and so many trials. It's going to mean that there should be a trial at every center right now for someone with this disease because that is the cutting edge. And the important thing, patients tolerated it well. It was feasible. It could be done. In any trial, you always have to ask, if you're adding something, are you making patients sicker? Are they going to have issues? And this trial showed that it was quite well tolerated. So I was very excited by that, seeing those data just a couple of weeks ago.
Yeah. No, I think it was really great news. Go ahead.
Roy, I don't know if you remember this. Well, I'm sure you do. We give a lectureship award every year at the Lung Cancer Congress down in Southern California, and you're part of that program always. One year, Tony Mock was the speaker, and he was the recipient of our grant. And he gave a presentation about going to war on lung cancer. And he talked about a lot of this way back then. And honestly, it was probably 7 or 8 years ago. It's like, hit it hard and hit it early. What do you think about that?
Yeah, so thank you for your support of that meeting and that lectureship. I actually gave it 1 year, and we're looking forward to being in person, by the way, or at least hybrid, in Huntington Beach, California, late this
Yeah.
July. And it'll be nice to see many people again. But yeah, I remember he talked about the art of war, and he showed
Right,
some of
exactly.
the ancient Chinese characters, and that's what it really is. We're fighting an opponent that is relentless, but we're better, and we have science on our side. And I would say, as we're talking about, we need to use all the different modalities, chemotherapy, surgery, and radiation. But now we have the immunotherapy, we have the targeted agents, we have the targeting KRAS, and it's how to combine these things together. And the thing that I've learned, and we have a large grant at Yale called a SPORE, a specialized program of research excellence. And I actually was just meeting with some of my team this afternoon. We need to now we're at a very important turning point in this disease, because we have all these tools, we have all these drugs, but we can't just mix things together willy-nilly. We're going to have to understand, if a cancer is not responding to immunotherapy, why? Is it because the immune cells aren't getting to the tumor? Is there a new resistance mechanism? And I would say, with everything we're talking about tonight, the diagnosis, the expert clinicians and treatment team, and then all these drugs, we need to figure out how to put it all together for each person. So that's happening. And it is a war, because you have to decide, when do you use this weapon versus that weapon? How do you combine things together? But Tony certainly we're having him back this year, by the way. He's going to be giving an
Oh,
encore
good.
this year.
I love
So I'm
that
going to tell
guy.
him that he needs to revisit that.
Okay, good.
I actually remember Tony's talk that year, and I even remember the suit he was wearing, because it was quite fantastic. I think, one of the things that's important to note here, and that we're talking about, and this is an opportunity for me to talk about the importance of screening and early diagnosis. And we're still looking at pretty dismal rates of screening, given that the approval's been around for several years now. When we're looking at now with the new guidelines and recommendations coming out, even opening up, that possibility for screening to roughly 16, 17 million people in this country alone, and still only having about 4% of those people participate. Exciting things are happening, right, in this early space. And I know a lot of you are watching because you've already been diagnosed. So screening is not relevant to you necessarily, but it might be relevant to your neighbor, or, a family member or a friend. So please, keep talking about screening and the importance of it, because I think, I know screening saves lives, and who better than you all to be sort of our army on the ground, encouraging those that qualify to get screened. Another thing I want to say, and Dr. Herbst said it, and Bonnie did too. We want to scream from the mountaintops everything that Dr. Herbst is talking about tonight in precision medicine, because everyone deserves to have this type of precision, diagnostics and treatment. And we're not there yet, but we're getting there. And even, Bonnie, when she was diagnosed in 2003 and ultimately had her surgery in 2004, not only did she receive, neoadjuvant therapy prior to surgery, but then she had interoperative, I don't know why that's always such a tongue twister for me, radiation therapy, after they did the lobectomy. And this was all after, her first, second, and third sort of folks told her there was nothing that they could do and she should go home and get her affairs in order. So, you know, keep watching us, become educated on your disease, and have these informed decisions with your care team. So, sorry, I just needed to do a little, little shout out there about that. So we've talked a little bit about combination therapy as it pertains to immunotherapy, and so I want to jump into immunotherapy because we get a lot of calls to our helpline and folks that we talk to all the time, and because of all the commercials and the amazing sort of direct to consumer advertising that's been happening, everybody thinks they need immunotherapy because it's the do all to end all for everyone. Can you talk a little bit? We touched on it, but can you talk a little bit more deeply about who should be receiving immunotherapy? How do we know who should be receiving immunotherapy and what those treatments look like?
Right. Well, immunotherapy is amazing. I've been very fortunate. I came to Yale just in early 2011, and Yale has quite a bit of history in this disease. Li Ping Chen, one of the who actually first described one of the people who first described PD-L1 is here. But Scott Gettinger and Mario Snow in our group had been treating patients with nivolumab as early as 2009, 2010. So we have some people now with lung cancer who are alive and doing great, from 2010, who got immunotherapy. People who had squamous lung cancer with no actionable mutations, meaning nothing that we could treat with one of these new targeted drugs. 3 prior chemotherapies, got these drugs and did amazingly well. There's no doubt. I've seen it many times myself. I've been involved in a number of the trials. Immunotherapy is just incredible how well it can work. The thing about it is it works that well only about 15 to 20% of the time. So 1 in 5, maybe a bit less. We still don't know exactly who those 1 in 5 are from the very beginning. We do know that there's something called PD-L1, and if it's high, that's part of the story. But even if the PD-L1, the marker, is way up high, still only half those patients see their tumors shrink. So we have to figure out what about the other half. And then for those that have the PD-L1 in the intermediate range, we're doing combinations with chemotherapy. We have different immunotherapy combinations. It works, but to variable degrees. So what I would tell people is, yes, you want to ask, is my tumor amenable to immunotherapy? First, I would say, is it amenable to one of the targeted therapies? Because if someone has one of those, you should use it first. But the immunotherapy is something one wants to consider. It's not without its side effects, but it can be pretty well tolerated under the right guidance and very careful scrutiny. But we're now in the era where we have to then take this to the next level. And what you'll see at many sites in clinical trials are combinations. This is what we're doing in our Lung Master Protocol. Combinations of immunotherapies, or an immunotherapy plus a chemotherapy, different things to try to then figure out how to overcome the resistance. But I will tell you that I would never have thought when I started out in the field in 1994 we'd see this type of effect with a drug. So it tells us that it can work. I'm sure there are many people on this line who are on immunotherapy and are benefiting. We still have many who can't benefit, or many of the people with the targeted drugs, the immunotherapy doesn't work as well actually in that setting. So we still have a long way to go, but we've seen the light at the end of the tunnel. It's just a very long tunnel.
Yeah, I think
Yes.
in this setting, and we have several online communities that we work with and monitor, and you're right. Like, we hear so many varying stories. We hear from one patient who was maybe on immunotherapy for a year, 18 months. They went off, and here they are 3 years later, still with no evidence of disease. And then another patient who maybe didn't do so well and progressed fairly quickly. So I think it is a very exciting time. I think there's still a lot of confusion within our patient population and our caregiver population, those who are out actively trying to find this information for their loved ones around immunotherapy. But again, I think it's points back, to why, as I've said over and over throughout this meeting, it's so important to become educated and have these conversations with your healthcare team about it.
I would just say that we first started using targeted therapy in 1997. We still are trying to figure out how to optimize it. It's moving to the earlier stages. Immunotherapy has only been with us really as standard of care for 5-6 years. And we haven't started to personalize it yet. So my prediction
Right.
is, and actually you have me wanting to get back to work now, we have to figure out how are we going to personalize immunotherapy. The same way we're looking at markers for targeted therapy, I would contest that the top centers, and then hopefully it gets spread throughout the country, are going to look at tumor markers and immune cell markers, create an equation and say, this is the cocktail of drugs one needs. Don't forget all this cell therapy, the CAR T cells and the T cell infusions. There's so much opportunity, but we still have to do the work. That's why we need the clinical trials. We need to support research, and but these trials are being done. But there is hope, and it's great that these things are all happening.
I
Roy,
agree.
do you know of any people out there that are working on repurposing drugs from other cancers that have the same markers as lung cancer?
Um, um, well, the repurposing of drugs, many drugs in the old days without personalization, were considered failures. And now I think, one of the things we talked about was sequencing. So yes, I think that if we why if you have 1% of patients with lung cancer have a genetic abnormality, let's say it's PI3 kinase, which we treat in breast cancer, why can't we find that small group of patients? Because there are 1.5 million patients with lung cancer in the world each year. So yes, I think we have to look at all the other tumor types. It's funny though, or it's concerning that sometimes a drug that works in one tumor type against the target might not work in the other, just like the EGFR in lung cancer doesn't work as well in other tumor types. But yes, I think we have to keep our eyes wide open. We have at Yale, by the way, a precision medicine tumor board every week. So we can't discuss every patient's case, but it's by referral, and we'll discuss 4 to 6 situations each week and look at the mutation, no matter what the tumor. So we don't care whether it's lung, breast, colon. We care what's driving that tumor, and then we have the experts, both clinically and also from the lab, the people that do the DNA sequencing come together and suggest what would be the best drugs. And again, repurposing is something that we can certainly do, Bonnie.
So you just
Thank
brought
you.
up something that we didn't necessarily have on the docket to discuss tonight, but I think it's important, and it was, a miss on my part. But you talked about tumor boards. Can you explain to the folks watching live and those that will come back to watch post live what a tumor board is?
Yeah, so see, my hair is getting gray. I'm as experienced as they get in lung cancer, and I still, whenever I have a difficult situation, I always refer to the tumor board. Why? Because I don't know everything, and I need to work in a multimodality way. And what a tumor board is, it's basically all the physicians and caregivers, the social workers, the nurses, the team gets together. It's once a week, sometimes more, and they discuss the surgeons, the radiation oncologists, the medical oncologists, the pulmonary oncologists, the pulmonologists, and then the people expert in all the different drugs, and the radiologists, the pathologists, and we give the tumor and the cat and the patient a fresh look. And then we say, 'cause, a lot of these decisions, what stage is a tumor? Is this lymph node positive or not? We talked about the rebiopsy. What drug should we use? It's not straightforward. So this is bringing together the group to reach consensus. We do it at Yale, just for our practice at our main site. But think about how important it might be if you're someone who's going to a distant site. It's more convenient. It's more convenient for your family. It's more convenient for you. In fact, that's where you should go. We should bring all these drugs and therapies to the community. But it's nice if it's all reviewed in a central way. And tumor boards are just so critical. And we actually have at a place like Yale, we run 15 to 16 tumor boards a week, for each different tumor. And we're now actually probably going to have to add a second lung tumor board because again, we want to review these cases. So I saw a patient today, and I said Monday morning at 7:30, my fellow, I usually work with a trainee, we're going to present this at our tumor board, and then we'll get back to you. And it's such a, and it's also where you train people and the doctors and the nurses. Everyone learns. So I would say you definitely want things to be reviewed at a tumor board, and most places now are doing that. Multimodality care, that's the key, and that includes the mind too. You want to have your social workers, you want to have your support groups. The support group is part of that tumor board as well.
Yeah, I think that's so important. And folks who, have regularly watched The Living Room have heard us talk for many, many years now about the importance of this multidisciplinary team, which is what you're talking about, where it's not any one doctor, but it's your entire care team, including the supportive folks like you're talking about, social workers and some support group leaders.
And at our
And they,
place, yeah. I'm sorry to interrupt. I was just going to say that one of the things that I'm very excited about now is, I'm in Connecticut, which is, you go up in the 95 all the way from New York all the way to Boston. And we have 15 sites now where we're treating patients. And what we're doing now is we're putting multimodality care at every site. So if you go to Greenwich and you're at a Yale site, you have a surgeon, a radiation oncologist, a medical oncologist who have all been at that tumor board. If you go up to Hartford, you have the same thing. That's the way, it's important to constantly ratchet up the level of care, do the sequencing and to learn and to bring the new therapies and adopt them as quickly as possible. So that's what's happening. I see it happening across the entire country. I'm very excited to be part of it.
And, we have a program called Community Centers of Excellence, and we're bringing on more and more community centers all the time. And this is where these people get the benefit of being able to get care close to home. But these people that are in the Community Centers of Excellence are reaching out to academic
Exactly.
sites like yours, and they're part of the tumor boards and things like that. And, more often than not in the community centers, they're used to doing, leg surgery and babies and all those things, and they have oncology, but they're not trained on every single cancer. And you know how many cancers there are. It's impossible for one poor oncologist at a community center to treat all of those cancers. So belonging to a center like yours and others is, a
Oh,
beautiful,
absolutely.
beautiful
And
thing.
even I walk across the hall and ask advice when I'm in the clinic.
Sure.
It's become, and it's good. We have so many options now. You want a thoracic surgeon who just does lung surgery, not cardiac surgery. You want a radiation oncologist, who is focused on the lungs because, again, the field is getting more and more specialized, and that's good. But then if you find that it's a therapy that can be delivered closer to home, people should get their therapy closer to home because that's more
Yeah.
convenient for
Yeah.
them, their family.
Yeah.
People have to work, and look, there are a lot of people with cancer. They can't all come to the big city, so you have to work as a collaboration.
Exactly. And they can help in clinical trials too, and do the needed blood draws and testing that are required for the clinical trial, but they don't have to leave their home arena to do it. That they can be done in the
Right?
community center, and those things sent off to the academic center.
We
So
do that, Bonnie. We see about, if we put, in our best year a few years ago, we put about a quarter of our patients on at our community sites. So you want the trials to be running because if someone has to think about a clinical trial, it means that they really have to be up on all the best standards of care. So it improves the practice just because you have those trials open. But then, of course, it might be, the patient who 10, 11 years ago got on the nivolumab as the first clinical trial. She's still doing
sure,
well. So clinical
sure,
trials can, and now more than ever, we're picking drugs better and they are having great effect.
yeah, but we have to bring the trials to the patient where they live and where they're
Absolutely.
treated, instead of making them fly across the United States, where they're leaving their family. They can't leave their work. I mean, it just makes all the sense in the world to bring it to them rather than make them find you. You
Well,
find them.
that's the lung map idea. A trial that's open at 700 plus sites, and in the community, with access to profiling. That's exactly the goal. And in fact, when we started that trial, I don't know if you know Ellen Siegel, and Friends of Cancer Research, but she was working very closely with
Yeah,
Rick Pazder and Janet Woodcock and the FDA. That was the goal of
yeah,
this, to get drugs
yeah.
to where the patients are.
I
yeah,
was working
absolutely.
with David Guevara at SWOG when the MAP trial was announced with
Exactly. I
Valley's
remember.
whole group.
Right.
Yeah,
Yeah.
And
I
our
think,
friend David Gindera.
Yes.
yeah.
Yeah.
we could have an entire living room and should have another entire living room talking about clinical trials, because I think it's come up a lot in the importance of them. And we know that a large majority of clinical trials actually fail before they ever get started because of the accrual issues. So there's a lot of things to consider there. I am going to give GoTo a plug before I move on to the final sort of piece that I want to cover, because I think it's a very misunderstood piece and an important piece of your care team and the care process. But as far as clinical trials go, quite often, particularly in some of the more rural settings around this country, it's hard to find these clinical trials. And GoTo Foundation has an amazing team of navigators that work a program called Lung Match. And what Lung Match is it not only helps you navigate your disease and helps you to better understand maybe the report coming out of your biomarker testing, but it will help to match you with clinical trials in your area. So huge shout out to the GoTo Lung Match team and all of the work they do to facilitate that process. So the last thing I want to talk about, which is, in my opinion, based on what I hear on the streets, is palliative care. Quite often when folks hear or their healthcare team, someone from their team tries to discuss palliative care with them, often they associate it with hospice as opposed to this sort of supportive nature. Dr. Herbst, can you talk a little bit about palliative care and why it's an important piece of the puzzle when patients are going through treatment?
Oh, absolutely. And I couldn't agree more. Palliative care is an important thing to bring in as early as possible. In fact, studies have shown that if you bring palliative care early, it actually improves the outcome and survival in lung cancer. Very often, especially now that we have these therapies that really work, it takes some time for them to work. Immunotherapy has a delayed, activity. Surgery sometimes can have, you have to do a big surgical procedure. Sometimes people have some side effects. So it is important to treat symptoms and allow people to feel strong and well as they're going through their therapy. So we actually have a very active palliative care program at Yale. Sometimes we even hire physicians who are both boarded in palliative care and oncology, working in this space. Because you want to treat the symptoms. Let's say we talked about Adura tonight, and someone's getting osimertinib, Tagrisso, for 3 years. Now, even someone might have some issues with fatigue. Someone might have a dry mouth. They might have some rash. These things need to be dealt with very early. Supportive care can help with that. So you're treating someone with immunotherapy, which can result in dare I think cure people. I actually think we're curing people with immunotherapy. But sometimes you have to get people through some processes where they might have skin or pulmonary or other issues. Of course, you might attack that with a pulmonologist, but supportive care, palliative care can be that important. So I really think palliative care, physical care, then let's not forget the social worker and the mental care as well, support groups. One of the things I love most is every November, I bring together my multimodality team at Yale and we have a lung cancer awareness event. And we're in the auditorium, and maybe this year we'll have to be outside on the field because they might not let us in the auditorium. But we're taking questions, and we're seeing how people are coping with this, and people get up and share their stories. So I think palliative supportive care is just so important in oncology. The oncologists and palliative care doctors work side by side, and as I say, I have several palliative care doctors. I have two now in my department of oncology, who work side by side with us.
I think that's fantastic, and amen to that, because I'm right there with you in believing in the importance of it. And I want to also remind folks out there that GoTo Foundation, especially from this support and education angle, is an extension of your care team. We are here. Our community support education programs initiatives are all important part of and piece of the patient experience, and we are here to bring that to you. And if it's something or need that you have that we may not have readily available, at least in-house, we will find it for you. particularly when it comes to support groups. And you just heard Dr. Herbst talk about that. You know, we oversee this sort of support group network around the country where we are in constant contact with the folks running these groups. And to go back to another silver lining, you know, although we were live streaming this event long before COVID, I like to kind of say we were ahead of the times and really prepared to kind of jump into this, you know, virtual role. One of the silver linings of COVID is a lot of this type of support has become available online. So again, please don't hesitate to reach out, and we've got some amazing social workers on our helpline that can help you with exactly what he's talking about. I want to be mindful of time and asked Dr. Herbst if he has any final thoughts before I go into some closing and some updates about what folks can expect next from GoTo Foundation.
Well, I'll just say it's an honor to be here. You know, I've seen it. I've taken care of many patients over the years. I've had family with this disease. It's been great to see the progress, but we're not stopping now. There's a lot more work to do, getting those that don't have access to care, these new therapies, but also continuing to find ways to treat the resistance. And I'm dedicated, and my team are. But we couldn't do it without groups like yours and GoTo and you know, creating awareness, supporting patients, and helping them to find us so that we can run clinical trials and bring the level of care as high as we possibly can. So thank you for allowing me to be here tonight. It's always a pleasure.
Absolutely.
Thank you, Roy.
A million thanks back to you for continuing to support us and be a close friend of the foundation. And hopefully next time we do this, it will be able to be in person again. So thank you, thank you, thank you. I'm going to wrap up quickly with some of our updates. We've been talking a lot about Bonnie's book. It's called The Living Room: A Lung Cancer Community of Courage. We were originally thinking it was going to go, you know, hard copy launch on May 4th. That has been delayed just a little bit to May 18th. You can still pre-order on Amazon, Barnes & Noble, and of course our website, but look for the hard copy launch on May 18th. Our next living room will be one of our rapid response breaking news living rooms on April 27th, and that will be at noon Pacific, 3 p.m. Eastern, where we have Dr. George Nieva and Barbara Gitlitz from USC coming, along with Stephen Huff, who's a survivor from Tennessee, talking about Alchemy, the Adario Lung Cancer Medical Institute's epidemiology of young lung cancer study. A lot of you that are familiar with us or have been following us for a long time know that several years back, we did a study looking at the genomics of young lung cancer, and this is the follow-up study looking at the epidemiology of young lung cancer. What is epidemiology? Well, tune in April 27th to find out. Our regular program, the next third Tuesday living room, will be May 18th. We've got Dr. Pasiane from Dana-Farber, along with survivors Hank Baskett, Jim Pantelis, and Gina Hollenbach, to have a conversation. This, as you might notice, is the same day as the hard copy goes live. So it's really a sneak peek into the Lung Cancer Living Room, a lung cancer community of courage, some of the folks who are highlighted in the book, and of course, our very own Bonnie Adario. So make sure to stay tuned for that. A lot of you know registration is now open for our second annual Summer Jam virtual 5K Your Way, which will be on June 26th. So please go and sign up at summerjam5k.org. And if you're an endurance athlete, check out our My Perfect Marathon program at myperfectmarathon.org. Please also consider joining our registry. Most of you know patient-reported outcomes are an important piece of the scientific puzzle, and we would love for you to come in and donate your information to the registry for future shared learnings. Again, a huge thank you to Dr. Herbst, to Bonnie, all of you watching live, those of you who will come back and watch post-live, Peninsula Television, for all the work they're doing behind the scenes to bring this to you. And of course, our supporters, Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly Oncology, Merck, Novartis, Regeneron, Sanofi, and Takeda. Thank you for continuing to support this very valued and important program for our lung cancer community. Thanks, everybody. Have a great night, and we'll see you soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.